Hello, hi everyone. It's my pleasure to share some slides with you about peritoneal dialysis catheter evolution updates and pitfalls. Actually, I have to thank my colleague, Professor Ahmed Aqi, for his kind invitation. Hopefully, you'll enjoy the slides. This is to declare that I have no conflict of interest with the presentation. We have some learning objectives where we will discuss some about the evolution of peritoneal dialysis catheter, what's the updates in the PD axis, and what is the clinical pitfalls that we may face during our clinical rounds. The story of peritoneal dialysis started almost 275 years ago. It started in 1744, where peritoneal lavage was first performed by Stephen Halls. Then 1877, experimental studies in the peritoneum were done. 1923, first human peritoneal dialysis by Ganter et al. 1946, actually this was the treatment with first acute renal failure was the use of peritoneal dialysis by Frank. 1956, the first intermittent peritoneal dialysis by Robin and Dolan. Then 1964, the repeated puncture method were introduced for this technique. 1965, the stellate catheter were introduced, which is the trocath. Then the milestone of the peritoneal dialysis, which was in year 1968, with the introduction of the Tenckhoff catheter, which were introduced by Henry Tenckhoff, which is the mainstay of the whole process of peritoneal dialysis nowadays. In 1976, CAPD description by Popovich and Moncrief in Austin, Texas, was first created, and then the APD and CCPD, continuous cyclic peritoneal dialysis, was started first in 1981. This is a Rosniak metal catheter, which was used first to flush and lavage the peritoneal cavity, after which the idea of peritoneal use as a dialysis procedure was started to be implemented as a modality for management of some diseases. Then Palmer in 1962 developed the first silicone catheter that sealed properly on the exit side to provide continuous access to the peritoneum, this for the first time. But actually it was single cuff, as we can see here. So it has a lot of leakage that happened by that time. Still, the start of the Tenckhoff catheter era, which is really the actual start of peritoneal dialysis success and story by Henry Tenckhoff, where he invented this legendary catheter, where, as we can see here, we have two Dacron cuffs here, we have external part, we have subcutaneous tunnel, and then we have the intraperitoneal segment. Actually, these two Dacron cuffs minimize the leak of peritoneal fluid and provided some good barrier for infection and decrease the incidence of peritonitis. Okay, so this means that it should be only one type of catheter that's used. No, actually we have two types of catheters. We have temporary PD catheter and permanent PD catheter. The permanent one that we have seen in the last slide, which is the Tenckhoff catheter, but for the temporary one, it is that one. As we can see here, it's made of plastic that is put over a metal trocar with a scalpel and connection. So this temporary PD cath, it means it cannot stay more than 72 hours in the belly of the patient, and then it has to be removed. But when we use it, actually we use it in hemodynamically unstable patient, in the presence of bleeding dialysis, in cases of difficulty of obtaining blood access, in cases of clinically significant hypothermia, where we can use the peritoneal fluid when it is warm to increase the body temperature in cases of hypothermia. What advantages does it offer? It offers that we will not need any systemic anticoagulation. It doesn't require highly trained personnel, nor experienced one or complex equipment. It's a really easy procedure. It can be done in 10 to 20 minutes, bedside procedure in acute cases, like we mentioned earlier, so that it's easily used and quickly initiated. And actually, the glucose content in the PD fluid will act as a caloric source for those patients who are acutely ill. But actually, it's not commonly used right now. This was used for maybe 10 years back. However, maybe some centers are still adopting this technique in acutely ill patients where neither regular peritoneal dialysis, neither hemodialysis can be used. So then they can adopt this technique with the following PD order, where you use dialysate solution as the regular dialysate solution you use it for CAPD, either 1.5, 2.5, or 4.25%. The exchange volume, usually you start with 20 ml per kg, and gradually you can build up the volume up to 40 to 50 ml per kg during 1 week, keeping in mind that the catheter should be changed every 72 hours. The cycle time can be almost 1 hour, 5 to 10 minutes for the inflow, 30 minutes to 40 for dwell time, outflow in 15 to 20 minutes. Meanwhile, you should keep an eye on serum potassium of the patient, and it should be supplemented most of the time due to frequency of hypokalemia that occurs. We have some limitation for sure, as since it's a blind technique, so a lot of complication may happen, and so it should be restricted only in acute kidney injury that have some expectation that it will recover very soon, and just in case of no available other methods, as we mentioned earlier, to manage such patients. We will go back to Tenckhoff catheter, which is the permanent catheter, as we mentioned earlier. As we mentioned, it was invented in 1968. Since that time, there were many attempts to provide another catheters with different shapes based on this catheter. As we can see here, we have Toronto Western catheter with double discs. You have swan neck catheter with 2 discs and 2 cuffs, T-fluted catheter, T-max catheter, straight catheter, Popovich-Moncurier catheter with elongated deep cuff, and coil catheter Missouri. You have valid 2. Okay. We will ask ourselves why this number of catheters have been tried to be used instead of that standard Tenckhoff catheter. Actually, the issue is they are trying to improve the catheter that is already made in 1968, which is the Tenckhoff, so that they can get the ideal catheter. Okay, so what is the ideal catheter? The ideal catheter should be reliable, with rapid inflow and outflow, with no leaks and no infections. So they tried to go further for many catheters to improve the original Tenckhoff catheter with the previous shapes and design that we have shown earlier. However, after all these kinds of catheter, the most currently commonly used catheter are the Tenckhoff catheter, the straight one or the coiled one, swan neck catheter, and Toronto Western catheter. The Tenckhoff catheter, actually, it has different sizes, starting from neonatal size, which is 31 centimeter, up to the universal size that we usually use, 47 centimeter long. Usually, you measure the catheter or the size of the catheter you want to implement in your patient by measuring the distance between the deep cuff of the catheter, which should be located first 2 to 3 centimeters below the umbilicus, and till the end of the straight part of the catheter, which should be the suprapubic area, so that where the catheter is inserted, this coil of the catheter should be in the Douglas pouch of the patient, like we see here. This is the original shape of the Tenckhoff catheter, but this is the coiled form, not the straight form. That the coiled part, or if it's straight, it should be in the Douglas pouch of the patient. Okay, but we have some special scenarios. Not all the cases are the same. Not all the cases are straightforward. Not all the cases are that simple. What if we have obese patient, abdominal wall defect, incontinent patient with a stoma or whatever? So before insertion of the catheter, what type of catheter we can use? We will answer all these questions at the end of the lecture, and hopefully you will answer it before I answer it. Okay, now let's say we inserted the catheter. What if, but after insertion of the catheter? You inserted already the catheter, but you have inflow pain, you have outflow pain, you have poor inflow, you have poor outflow, you have catheter migration or catheter leak from around the catheter, or you have external cuff extrusion. All these questions also would be answered at the end of the lecture. For the permanent peritoneal dialysis catheter, the chronic one, it has two major parts, intraperitoneal and extraperitoneal part. The extraperitoneal actually it's also have two parts, subcutaneous part and external part. As we can see here in this cartoon, you can see here this arrow that points to the intra-abdominal segment where the catheter from the deep cuff to the Douglas valve, this is the intra-abdominal segment. Then we have the deep cuff. Then we have the internal subcutaneous subfacial tunnel segment. Then we have the outer cuff, okay, which is still subcutaneous. Then still we have the subcutaneous tunnel. Then we have the exit site from which the catheter would leave the body. Then we have the external segment that we all see coming out from the belly of the patient. As we can see here in this diagram, you can see that this is the deep cuff here that is fixed to the anterior rectus sheath with the 4 quadrants, okay. Then you have subcutaneous tunnel. This is the subcutaneous deep cuff, and then goes through the subcutaneous tunnel to come out of the skin. And here the catheter comes down to the Douglas pouch, coil type. Here is the omentum, here is the bowel, and here is the peritoneum. This is simply how it is fixed in place. Then we will go back to some details of other previously mentioned catheter, that like this catheter, which is called max T flow generation with 2 discs, that have been invented in a trial to improve of the outflow and inflow of the peritoneal dialysis patient by providing a big surface area of the catheter inside the abdomen. Then they go for this catheter. It's called the Paolo catheter. It's called self-locating catheter. Self-locating because it has a titanium or metallic part at the tip of the catheter that tries to fix the catheter in place by the gravity, okay, through its weight. As we know, one of the common problems in peritoneal dialysis is the catheter migration, because the bowel movement takes the catheter from one place to another sometimes, especially in cases of constipation. So they try to put a weight at the end of the catheter so that it will try to fix the catheter in place. Now we go to this catheter with a reservoir at the end of the catheter. It's called Valley 2 catheter, whereas this reservoir will act as a tank that it will always pre-fill so that it will allow more fluid to be ready to be drained from the patient, and also it will try to fix the catheter in place while it is filled with PD fluid by its weight. As we can see here, it's fenestrated to allow some fluid to get in, and it will rest down in the Douglas pouch. Another type of catheter to improve the inflow outflow is called Ronco double lumen catheter. As we can see here, we have 2 lumens of the catheter. that if we could have two separate lumens where the flow comes in and the flow comes out in a separate way, not like the Tenckhoff catheter or all previous catheters that have one single lumen. So they thought, what if we could just make two separate lumens, may it have better inflow outflow. Then they went to another catheter, which is Paciencia catheter, which have a short part of the catheter, like we can see here, this short intraperitoneal segment, as it's used in some situations like those with abdominal wall defects or so on, so that you can go down in the abdomen to insert it. As we can see here, this is the standard place where you can insert your catheter, which is almost 2 centimeters below the umbilicus. But in some cases, if you need to use this Paciencia catheter, you can use it downward and almost 10 or 15 centimeters below the umbilicus, so that if there is any abdominal wall defect here, you can get away from that. One type of catheter, as we can see, long catheter, it's called swan neck. Swan neck, as we can see here, pre-sternal catheter. Actually, this catheter has some specific uses. Such patients that are quite tall, that you need a long catheter, that's not enough, because actually this catheter is two catheters that are fixed together with a permanent bend at the end. Okay. The catheter will go in some details of the catheter composition, actually, and the shape of the current catheters. As we know that we have subcutaneous tract, the tract that is under the skin, where we have either straight subcutaneous tract or bent subcutaneous tract, which is usually permanent. It's usually a permanent. This actually straight subcutaneous tract, actually, it may facilitate more catheter migration because it's straight and it will be easy to be moved around either right or left, and the catheter may migrate, and also it may have some more external cuff extrusion because of its straight shape design. Meanwhile, in cases of permanent bend, as we can see here, it's used in the swan neck catheter, and swan neck catheter with pre-sternal extension, as two catheters are connected together with this inverted U-shaped arc. Actually, this U-shaped arc, it will prevent what we call memory recoil of the catheter. Sometimes the catheter would try to straighten up by its memory effect. So the presence of this permanent bend, it will abolish this memory effect of the catheter, and the catheter will try always to be in place. Let's go for the anchorage of the catheter. How the catheter is fixed in place. Actually, it's fixed in place through two Dacron cuffs, as we can see here. These are cuffs made of Dacron material that allows ingrowth of fibrous tissue all around to fix the catheter in place. Most of the catheters are fixed just because of their fibrous ingrowth into the cuffs, not because of suturing. And the distance between the two cuffs usually 5 centimeters. However, it's not appropriate for obese patients. We should use more space between the two cuffs if we are using it into obese patients. Other types of cuff actually use single cuff in the catheter. It's called single cuff catheter, usually used in pediatrics because of the small abdomen size. So you don't have the space to insert a double Dacron cuff, so you insert a single one. However, it's more likely to have more frequent peritonitis, and the time for the first peritonitis episode is quite shorter than the double. With the use of ultrasound, actually it helps us a lot to identify some complications that may arise during the follow-up of the patient. Here's the ultrasound that shows the deep cuff, which looks very nice, with no collection, with no fluid all around. But in case of peritoneal leak, subcutaneous infection, you can see this image where you can find this gap or this hypoechoic space where the fluid is collected all around, or sometimes, like we see here, in some parts of of the subcutaneous tunnel that gives you the idea that there is some fluid collection in the tract of the subcutaneous tunnel. It could be fluid, it could be pus, can be aspirated to check what is the nature of the collection. Catheters usually made of silicone. Till now, silicone is the most frequently used material as it's inert, soft, flexible, and it can tolerate different types of temperature. At one time, they tried to invent another catheter using polyurethane material, as polyurethane allowed wider lumen since it has thinner wall of the catheter. So it can provide more quicker flow and shorter dialysis duration. However, they found that polyurethane was cracking under the exposure to different temperature. When exposed to more warm fluid, sometimes it cracks and causes some leaks, which is quite unpleasant in such patients, and it will cost us a lot to stop PD fluid or peritoneal dialysis and shift the patient to hemo and then remove the catheter, insert a new one, silicone. So it's a big dilemma. So it's now almost not used in most of the centers. Some centers also adopt the idea of coating the external side of the catheter with antibiotics on the virtue that it may decrease the incidence of infection. However, no clear clues or RCTs that suggest that assumption. To insert the peritoneal dialysis catheter, actually we have three techniques. I will try not to go in details or in depth of these techniques. However, I think it will be interesting for you as a nephrologist to know all about these techniques, even the surgical technique. We have blind technique, surgical technique, and we have peritoneoscopic visualization technique. Peritonitis actually constitutes the most common cause of transfer of a patient from PD to hemodialysis. Okay, what if there is one method of insertion that has higher hands or good percentage of keeping the patient out of peritonitis or with less peritonitis? Actually, there is no technique so far of insertion of peritoneal dialysis catheter consistently proven to be superior in prevention of peritonitis. The three are almost the same. Then we will come to a very interesting question, and I think all of you have been subjected to. Surgeon or nephrologist should insert the PD catheter. Actually, there should be no fights. Actually, the more dedicated, the more experienced, the more willing one, he should win this argument. Because actually, the best for the patient should be done, irrespective of it's a surgeon, nephrologist, whatever. We have different and some principles of catheter placement that should be always taken into account so that it will minimize the long-term complications that we may face. First, internal deep cuff should be always secured in the musculature of the anterior wall muscle, which is the rectus muscle, so that will be fixed in place. In addition to external subcutaneous cuff should be no less than 2 centimeters from the exit site. We will see this in the next slide, so that it will not allow to cuff extrusion easily, and the exit site always should be facing downward or at least laterally, like we see here. If the exit site is facing down, so all pus, dirt, sweat, and water will come down by gravity. It will not be collected onto the exit site, as we can see here. If the exit site is facing upward, all these factors would be accumulated and will lead to exit site infection, and we will face a lot of problems. Okay, do we have any consideration in general just prior to fix a catheter or implant a catheter? Yes. First, you have to check for any herniation, any weaknesses in the abdominal wall. If the patient have any hernia, any weakness should be corrected at least 4 weeks before the procedure. And prior to the insertion, skin should be marked for the exit site. You should mark your exit site on the tummy of the patient before the insertion. And as we agreed that exit site is very important to determine its direction, and its position. Actually, the exit site, whenever you mark it on the patient, it should be marked while the patient in upright position. Upright position, it means he should be seated or standing. Never do it while the patient is lying flat, because whenever the patient comes straight during doing the later on dialysis session, by gravity, the abdominal wall would move with the catheter and it will change into position, so that it will have some kinks that will change all the inflow and outflow procedure. So always do it while the patient in upright position. Mark where you will make your incision for the exit site, and the exit site should be actually above or below the belt line. To avoid scars or abdominal folds, you should have go away from these scars or abdominal folds. You should take into account the line of vision of the patient, because the patient should have a direct vision for his catheter. And also you should keep in mind your patient is left-handed or right-handed, so that it will be easy for him to use the catheter you provided for him. One size fits all? Actually, no. One size fits all, what we mean here, we mean one catheter, one exit site is okay. So one exit site in the abdomen of the patient and just 2 to 3 centimeters below the umbilicus, as we mentioned here, this is the standard. But this doesn't fit all patients. There should be flexibility in choosing your exit site. We have 4 exit sites actually. We have pre-sternal exit site, we have upper abdominal exit site, mid-abdominal exit site, and lower abdominal exit site. This depends on what? Actually, this depends on the following. If you have a patient with high belt line, you can use lower abdominal. If you have a patient with low belt line, you can use mid-abdominal exit site. If you have an obese patient like you see here with floppy folds, you have to use upper abdominal exit site. What if you have, sorry, I skipped that one, because if we have one patient that he has morbid obesity, stomas, we can use pre-sternal extension. We can see here that in this patient, we had to change the site of the catheter here from the lower abdomen because of the ulcers, as the exit site comes into the skin folds here. So we had to remove the catheter and we put it pre-sternal. See, it comes out from the front of the chest of the patient. Okay, so what precautions should we have before the insertion? Actually, we have to be ready that the patient has no bowel problems. He should have at least 1 or 2 laxatives before the procedure. We need open bowel. We don't need any constipation. He had to empty his bladder. We should do some nasal swab and to use meprisine intranasal twice a day for 5 to 7 days if he's Staph aureus carrier. Some prophylactic antibiotics are used just to prevent the risk of early peritonitis, which had been shown in some studies. Whenever you insert the catheter, the intraperitoneal portion of the catheter, actually it should be placed between the visceral and the parietal peritoneum down into the Douglas pouch. Never put the catheter into the omentum, because if it came into the omentum, it will have omental wrap. It will be very difficult to get outflow of the patient. Always have very poor outflow, and so that the catheter should be actually put with caution between the loops, not into the loops. For the surgical technique, I will just go very fast for some details, as we have this surgical technique. Still now, this is the commonest technique used in placement of coronary peritoneal catheter out of the 3 techniques. It's done by local anesthesia or light general anesthesia. We have 2 approaches, either lateral approach or paramedian approach. Any type of catheter actually can be inserted via the surgical approach. We have only 2 to 3 centimeter long incision, which is located 2 to 3 centimeters below the umbilicus, either, as we mentioned, in the median or pararectal approach, we have to snip the skin, only 2 centimeters snip into the skin, go deep to reach the anterior rectus sheath. Whenever you reach the anterior rectus sheath, then muscle splitting of the rectus muscle, and it should be longitudinal. It should be muscle splitting, not muscle cutting, because if you did muscle cutting, actually you will have hernia later on. So always make it as a muscle splitting. Then you will have the peritoneal membrane just behind the posterior rectus sheath. You can just snip it, and you can introduce your catheter under the use of the trocar, so that it will be into the Douglas pouch, deep into the peritoneum, and then the peritoneum should be tightly closed in like a pouch around the catheter, and then the deep cuff should be sealed and sutured to the rectus muscle from 4 quadrants, and then the rectus sheath is closed over the deep cuff. Okay, now before closing the abdomen of the patient and making subcutaneous tunneling, you have to check the patency of the catheter since you closed the peritoneum. Because if you closed the whole procedure and you made the external subcutaneous tunnel, you will lose a lot, because sometimes the catheter will not work from the first time. So you have to check for the patency of the inflow and outflow. You can infuse 1 liter of PD fluid over 5 minutes and allow equal time for drainage. Or you can inject only 60 ml of normal saline, and you can observe if 40 ml are easily aspirated by the syringe. This means that your catheter is in place and you are happy, and you can just continue with creating your subcutaneous tunnel and external part of the catheter, and then you can close the wound. What about the laparoscopic approach? Actually, this has a big advantage, because most of the centers are now equipped with laparoscopies, and most of the surgeons are trained. Actually, need only 2 trocars, 5 to 10 millimeters are used, one in the paramedian location, where the catheter it should be inserted and it holds the catheter, and the other one in the pararectus location in the opposite side, where you can handle the catheter. And actually, the advantage of laparoscopic procedure that it allows you direct visualization where you are putting your catheter. Actually, even in the surgical one, you cannot see properly where the catheter is going in. But with the laparoscopy, actually, you can see where exactly it is there. As we can see here, these are the trocars used for the PD cath insertion by laparoscopy. Here, one in the paramedian, where the catheter, as you can see, can be forwarded through this trocar into the Douglas pouch. And then this is where the other hand that will help to catch the catheter and direct it. Like we can see, he is catching now the tip of the catheter, and he will try to direct it in between the loops to reach into the Douglas pouch, and then he will create the external cuff, and that's it. Easy, simple, reliable. Okay, let's go to the third one, which is the blind placement. Actually, it's called Seldinger technique, which maybe the nephrologist should be happy with that, because this technique is commonly used by the nephrologist. It comes into a set, like we can see, of trocar, cannula, and the catheter, guide wire, scalpel. Everything is ready for the nephrologist to put it as a bedside procedure. Simple, safe. You have to split the sheath and to allow the catheter to go in to reach the outer surface of the fascia. And whenever the catheter is held in place, the catheter guide is stripped away. It's called pull-apart system. You can just strip it away, and you will find the catheter. Like you can see here, you can just strip it away, and it will go directly forward. As you can see here, you will strip it and push the catheter. You will strip it from here. And then you can push the catheter. It will be just over the anterior rectus sheath in place. This is not commonly used right now, but I think you have the right to know about it. Popovich-Mokriev technique. It's a technique that had been used for those who could have use the catheter after a long time. You are not in a hurry to use the catheter right now, and on assumption that the use of this technique would decrease of incidence of infection, as what they are doing is that the external limb of the catheter that should be subcutaneous, actually it is buried under the skin. So it is all through under the skin and it's closed above by sutures. It will not be exposed outside the skin like this unless weeks or months, even whenever the patient is ready to receive his dialysis. It was assumed that this would decrease the incidence of peritonitis, but no RCTs are supporting still this evidence, and this technique actually is not that commonly used. After insertion of the catheter, we have some goals to keep ahead. So we have to minimize bacterial colonization. We have to minimize and prevent trauma to the exit site or any traction on the cuffs, especially they are going to grow fibrous tissue, and to stabilize the catheter in place, you have to secure the movement of the catheter well, and you have to minimize intra-abdominal pressure to prevent any leaks, to avoid later on complication of having leaks. And how to manage that, it's somehow difficult because you have to rest the patient for extra 4 weeks till the cuffs of the catheter start sealing the peritoneum. And immediately after insertion, as we mentioned, we have to flush the catheter or the peritoneal cavity hourly with 50 ml of PD fluid. We can put heparin, 500 to 1000 units per liter can be added in case you can see some fibrin or blood clots coming out from the effluent. Once the effluent is clear, the catheter can be safely capped. In general terms, it's advisable to minimize the movement of the catheter and handling until healing takes place. Actually, when you use or insert a PD catheter, you should have to keep it in place without usage. We call it break-in period for 2 to 3 weeks, not less than 2 weeks. Below 2 weeks, you will have many complications, especially leakage, which will lead to further delay of the start of the PD. One question may arise, which is, okay, what if I need to do urgent dialysis for him? I have to take it immediately. Okay, if you have to undertake dialysis immediately, okay, you can still use this catheter away from the 2 to 3 weeks we mentioned earlier through using small exchange volumes with frequent cycles while the patient in supine position. Patient should be in supine position so that it will minimize the intra-abdominal pressure and will decrease the incidence of leak. Exit site of the catheter, where the catheter leaves out the tummy, actually there is no consensus as regard specific procedure, cleansing agent, dressings, and methods of immobilization. Actually, this is center experience and depends on the physician's opinion. However, it's important to remember that not to forcibly remove any crust during cleansing, and the exit site should be always kept dry. So try to avoid using any ointments. Try to keep it always dry, and better to avoid also povidone iodine or hydrogen peroxide in cleaning the exit site, because povidone iodine, hydrogen peroxide, actually sometimes they react with the catheter material itself, and it may lead to some erosions on the long term. And now we'll go back to our clinical problems. As we mentioned earlier, what if you have obese patient? What if you have patient with abdominal wall defect? What if you have incontinent patient? The ideal solution is to use swan neck with pre-sternal extension, so that you will keep your exit site away from any incontinent areas, any abdominal defects, or any skin fold that will make any compression or kinking into the catheter. What if you have catheter extrusion, which actually about 3% of the patients would have catheter extrusion, and this happens actually because of the frequent use of the catheter after some time. As we can see here, the external cuff under traction will go out of the skin. See, the catheter goes out of the skin because of the permanent continuous traction on the catheter. So the only solution here is to shave this. You can just shave it with a scalpel, shave it off, take it out of the catheter, and be very careful not to make any cracks or any pins into the catheter, and keep the catheter as a single cuffed catheter, no problem. And later on you can change the catheter, but there is no emergency in dealing with that issue. What if we have poor outflow? The outflow of the catheter takes too long, and we found this is because actual catheter migration, as the catheter, as we mentioned earlier, it should be in the Douglas pouch here, down, as we mentioned here. But as we can see, it was shifted up in the hypochondria. Then we can use this De Paulo self-locating catheter that it has the weight to keep it down. What if the poor outflow was because of omental wrap? How we can be sure? We can be sure through injecting contrast material. As you can see here, the contrast will not go through the side walls or side holes of the catheter because of the omental wrap, and will go from the tip of the catheter because it's free. Then you have to do partial omentectomy by laparoscopy. As you can see here, you can do some partial omentectomy, remove parts of the omentum, and you can, if it's frequent, you can use Toronto Western catheter with 2 discs, so that will give you a space all around the catheter to avoid omentum adhesions or wrapping later on. After insertion, what if the patient have a lot of inflow pain, mostly because of the jetting effect of the peritoneal fluid while it comes in? What if the patient have outflow pain because of more dryness of the peritoneal cavity, and the tip of the catheter hits the Douglas pouch and the bottom of the patient, and the patient feels pain? If you have poor outflow, if you have catheter leak, actually the ideal for all of these is to use coiled catheter, so that will not have tip to hit the pelvis, or it will decrease the jetting effect also of the fluid, because it will be distributed all over the side holes, and this beads and disc actually will decrease the catheter leak that much. We will go for some accessories that are being used. I think you have seen it many times for the PD catheter. You should have some belts for the patient that can be used later on to ensure immobilization and minimize adhesive that is being used and make some allergy and skin crusts all around the catheter. Could be ready-made, or it can be tailored for the patient. Last slide, actually, we have this PD catheter first aid repair kit. Actually, should be there in any peritoneal dialysis catheter, in any peritoneal dialysis unit, as it contains this 15 centimeter silicone rubber catheter extension in cases of accidental cutting of the external part of the catheter. You will face some patients that sometimes they cut their external part of the catheter by mistake. Then you have to use this external rubber extension to overcome this cut part of the catheter. And there is no need to change the catheter at all if you inserted this piece. Then you have this glue mold with the use of this high-grade medical silicone adhesive. If the catheter had any cracks or any leaks from the external part, you can put some glue all around here in this mold, and put this shield all around, and just close this mold, and after 20 minutes you can open it up, and the catheter is totally sealed and perfect to be used. And then you can, at ease, you can arrange for catheter exchange later on. Thank you very much. I hope you enjoyed the lecture, and I'm happy to hear any questions later on. Thank you.